Hi, everyone. Thank you so much for joining us. I'm Sammy Lucas, and I'm going to be your moderator for this webinar. We're looking at about 45 minutes, maybe an hour. I'd like to acknowledge that we're hosting this webinar from the lands of the Gadigal people of the Eora Nation, and I also acknowledge the traditional custodians of the various lands on which you all join us from tonight, and the Aboriginal and Torres Strait Islander people participating in this webinar. So on behalf of the Pain Foundation, thank you all for joining us. We'll be hearing from our wonderful guest speakers tonight. We've got Professor Paul Glare, Associate Professor Claire Ashton-James, and Senior Researcher Amy McNeilage. So they'll be sharing their expert advice and insights from their important research. As I said, this webinar is being recorded tonight. Media are attending as well. So as some background, the Pain Foundation is a non-profit organisation that provides funding to the Pain Management Research Institute for their research and clinical work into chronic pain management. It's a big job. It's an important job. 1 in 5 Australians are living with and managing chronic pain. 1 in 5. And I'm guessing, like a lot of you that are joining us here tonight, I'm one of the 1 in 5 people that live with and manage chronic pain. I was introduced to the Pain Foundation through a friend of mine who's currently the chair of the foundation, Liz Rowell, and I was really interested as someone who lives with chronic pain to learn more about their work. So for anyone who's ever heard me on radio or read any of my columns, you're already aware that I am a bit of a chronic oversharer. So I'm very happy to share my personal pain journey with you as an introduction and an understanding of my connection and why I'm so interested in the work of the Pain Foundation. So just briefly, I was in a car accident in 2015 and I ended up with a pretty awful case of whiplash. And despite countless treatments and various physio appointments and all kinds of medical specialists, the injury didn't heal, the pain didn't get better. In fact, it got worse. And eventually, through the insurance process, I was pretty shocked when the medico-legal professional opinion for the treatment of my injury was to literally, in his words, live with it and manage the pain for the rest of your life. Not ideal. And then a couple of years after the car accident, after living with chronic period pain my whole adult life, see, I told you, oversharer, sorry, I was diagnosed with chronic endometriosis. So in summary, as any woman who's ever had endo will tell you, surgery can only do so much. But in summary, I've been living with and managing chronic pain for many, many years. And by managing, that usually means medication. So Nurofen, Voltaren, Advil, Naprogesic, occasionally Endone when it's really bad. And I know a lot of you that are watching us tonight are familiar with all of the above. And I know that many of you have your own chronic pain stories and journeys, and a lot of you have suffered from much more chronic pain than I've been through. The reason I'm so interested in tonight's webinar is because a couple of years ago, I was in hospital for a routine colonoscopy. See, overshare, can't help it. And the surgeon had a little quiet word to me after the procedure and said, I strongly advise you to stop using opioids and anti-inflammatories because my system didn't agree with it. So now that's why I'm so interested in the work of the Pain Foundation, and especially the conversation we're having here tonight, which is about the importance of deprescribing opioid medication for chronic pain. What other options are there? I think we all want to know. I'm keen to hear more. I'm sure you are too, and our speakers have a lot to say about this subject. There will be time for questions after we've heard from our speakers. Just type your question into the chat box or the little Q&A box you can see at the bottom of your screen there. And if you could just identify who you are. Are you a patient? Are you a researcher? Are you a health worker? Are you from the media? And also let me know if there is someone you would specifically like to direct your question to. So enough from me. Let's get into it. We've got so much to discuss. Let's hear from our speakers. Firstly, I'd like to hand over to Professor Paul Glare. Paul, over to you.
So, yeah, thank you. In the webinar tonight, we want to tell you about some of the research we're doing at PMRI to improve the care of people with kind of problems that Sammy shared with us. And as the title of the webinar suggests, There is an opioid epidemic in Australia, with overdoses surpassing traffic accidents as the leading cause of accidental death back in 2014. And that equates to 3 or 4 deaths a day, which are needless, let alone countless admissions to hospital, presentations to the emergency department. It's estimated from Canada that 1 in 400 people using opioids long-term will develop a serious harm like an accidental overdose or death. And that's very different from the message we were getting 20 or 30 years ago that these drugs were safe and effective for chronic pain. You know, the opioid epidemic is really just one manifestation of a much bigger problem of chronic pain and the lack of access to effective treatment that many people face. Surveys indicate statistics like pain being the commonest reason that people go to the doctor. Chronic pain affects 1.5 billion people around the world. That, like we heard, that's 3.25 million adults in Australia. And it's the leading cause of years lost through disability around the world, and also causes a great deal of depression and anxiety and other distress. And despite what we've been hearing about the opioid epidemic, the reality is that 30% of people with chronic pain are still taking these drugs that are unsafe and ineffective. So, you know, it begs the question, why are so many people still taking opioids when they don't work and they're harmful? And I think there's 3 main reasons. So firstly, there's a misunderstanding on the part of many people, including a lot of healthcare professionals, that chronic pain is really just a persistent version of acute pain. We know opioids work for acute pain, like after an operation or in the short term after an injury, but they're not the treatment for chronic pain, and more education on this is needed. Secondly, there's a lack of access to the kind of treatments that are safe and effective, such as pain self-management strategies. And then thirdly, we know from our research, which my colleagues will tell you a bit more about in a minute, that people need a lot of support outside of visits to a professional because of the distress and disability and isolation that chronic pain causes. So what's PMRI doing to address these problems? Well, firstly, we've shown that our pain self-management programs, such as our well-known ADAPT program, are effective for improving pain and reducing the reliance on opioids. And we've shown recently that these methods can be delivered by telehealth, which is overcoming some of the access problem for rural patients. The graph I've got on the right there shows you the effect on reduction of reliance on opioids in people doing ADAPT. This is research that was led by my colleague, Professor McNeilage, published in the journal Pain a couple of years back. We find that more than 70% of people are taking opioids when they come to our program. And prior to doing ADAPT, we get that down to about half. But after doing ADAPT, less than 10% of people are still taking opioids. And the most important point was, a year later, as long as people are continuing to practice the techniques they learn in ADAPT, that they'll still be off opioids. So that's the first thing we're doing. The second thing, our pain education unit is upskilling clinicians in pain management. We run our flagship Masters of Pain Management, and we host a number of webinars like this and workshops for professionals during the year. And I'll now hand over to my colleague, Professor Claire Ashton-James, who will tell us about our social cognition and pain lab, which is developing digital interventions to provide additional support to people tapering opioids. So thanks very much, and I look forward to answering questions later.
Thanks very much for that introduction, Paul. Thanks very much also, Sammy, for sharing your story with us. It's always really nice to hear the word from the horse's mouth, so to speak. In the research that I'm doing with Professor Paul Blair and also Amy McNeilage, who you'll be hearing from in a few minutes, we are looking at digital interventions to support people to reduce their reliance on opioids that they're taking for pain management. And a lot of this research, in fact, all of this research has been funded generously by philanthropists and generous donations to the Pain Foundation. So we're really proud that actually all of this research that we've done has been funded by generous donations from private contributions to Pain Foundation. One of the first studies that Paul and I conducted was an experiment we conducted that was funded by the Saltieri Family Foundation and the Woodend Foundation as well. And we conducted an experiment to understand patients' emotional responses and attitudes in response to opioid tapering advice. And we did this study with patients in the clinic at PMRI. We were expecting that patients would, we conducted the study because we wanted to know the proportion of patients who had an angry or negative attitudinal response to opioid tapering advice. A lot of clinicians had told us that, you know, it was bad news, that people didn't want to receive this advice. And so we were really just trying to quantify the amount of anger and distress in response to opioid tapering advice, so we could see what clinicians were dealing with. And partly that's because an additional interest of mine is clinician burnout. But what we ended up finding was that, in fact, only about 1 in 7 patients experienced anger or distress in response to opioid tapering advice, and very few patients experienced any negativity or negative attitude towards opioid tapering advice when it was framed as an alternative, with the offer of an alternative. So, in fact, the majority of patients in our clinic, at least, were satisfied with advice to reduce their reliance on opioids when they were provided with alternative pain management support, and specifically that was, in this case, multidisciplinary pain care. When patients were not provided with any alternative to opioid therapy for chronic pain, then they were more likely to be distressed and angry in response to this advice. And so from this, we took it that, you know, a lot of this response to opioid tapering advice that might be negative really may depend on whether or not patients are being provided with any alternative strategy for managing their pain. So the difficulty is that tapering can be challenging. One just need to check something. When you provide people with, even when you provide people with multidisciplinary pain care, and we conducted another set of studies. This was funded by the Saltieri Family Foundation. And in this case, in this particular study, we interviewed 20 patients from not just our clinic, actually, but also a rural clinic, a rural GP clinic. And we asked them about their experience tapering opioids week on week for 12 weeks, for the first 12 weeks of their opioid taper. And what we discovered was really, really interesting. We found that not all patients had challenges with tapering. Not all patients had increases in pain intensity. Not all patients had increases in distress, but a lot of patients did. And everyone had an individual trajectory. Everyone had a very different experience. And it's also important to note that people's experience of pain in response to tapering was not necessarily associated with increases in their distress or increases in their disability. Everyone had these very individual trajectories. And so we really wanted to know, based on this data, we looked into it and we asked ourselves, well, what is determining how challenging and the nature of the challenge associated with tapering? And we identified that patient distress in particular while tapering was very common, but was really related to the availability of informational and socio-emotional support. That if you provide people, that those patients in our study who had social support and a good or a good relationship with their healthcare providers, they had a much easier time of it. And so from these two pieces of research, we can deduce that tapering is not necessarily going to be taken as bad news if you provide people with an alternative. And then when you do initiate a taper with patients, they do actually often need extra support on top of what is provided by their healthcare provider. They need to have good social relationships, steady state at home. The challenge, however, with providing patients with really strong support while tapering is that partly due to COVID impacting the prevalence of chronic pain in the community, there is a high demand for multidisciplinary pain care and social support while tapering is at an all-time high. The need for social support is at an all-time high, and access to these supports remains really challenging, and perhaps more challenging than it's ever been. So Paul and Beth Darnell and I wrote a piece for Pain, a leading pain journal, where we suggested that maybe digital health technologies could be an opportunity. They could provide patients with continuous support for pain and withdrawal symptom management during the tapering process. So we then conducted a study with the help of the GNP Knock Foundation to understand, well, what do patients think about digital support for pain management and opioid tapering? Because of course, if patients aren't interested in digital support for tapering, then there's no point developing digital interventions. Like it's absolutely necessary to involve patients in research and ensure that what you're developing is as interesting and satisfying for them. We spoke to 21 patients from a very diverse backgrounds, women, men, large age ranges from metropolitan, rural and regional areas, from tertiary and primary care with varying levels of social support, diverse and cultural and linguistic backgrounds, and variable income and education levels. And these patients told us that 100% of them owned and used mobile phones, 81% were interested in SMS-based support versus 71% in app-based support. So there was a preference for SMS-based support rather than more technologically, savvy apps and things like that. Really low tech and was really the preference of patients. And then patients also said that they had a higher self-efficacy for engaging with SMS interventions rather than an app-based intervention. The patients in our study also told us the sort of content that they would want in this SMS intervention. They told us that they would like to have information about pain management strategies, that they would find it helpful to have information about what to expect while tapering down their dose of opioids, to have reminders about opioid-related harms to help them to remain motivated to continue tapering their opioid medications, and to provide them with reassurance in the form of validation and emotional support. So based on this extensive and rich feedback that we received from patients who have chronic pain, live with chronic pain, and were tapering opioids at the time of their interviews, we developed a library of SMS, which we then had validated with input from expert clinicians, including physiotherapists, psychologists, and pain medicine specialists. Here's some examples of the SMS that were developed. For example, you can only manage pain one day at a time. Every day is different. Today might be hard, but tomorrow may be easier. So that's an example of something that's reassuring, providing them with some hope. And we found subsequently that there have been some studies showing that pure social support delivered by text message has been effective in helping people to manage chronic pain. We conducted a pilot study with the support of the Ernest Hein Family Foundation, and the feedback we've received so far has been really encouraging. Our one participant says, "At first I was not too sure about the whole thing, as I felt it was not focusing on the now. But as we moved along, I was close to looking forward to getting the text messages, as I found them very useful, as it helped me to ponder and then put into words what was going on." So a lot of the feedback we get from people who are using these text messages in our pilot study are that they're skeptical to start with, happy to receive them, and then come to really enjoy that sort of daily meditation twice a day, getting a text message that tells them to stop and reflect, plan their day or reflect on their day and prepare for the next day. So our next steps are we are conducting a multi-site clinical trial, also funded by the Ernst Family Foundation. We are really very highly motivated to ensure that this digital intervention is feasible and acceptable and accessible to people in rural and regional areas where access to multidisciplinary pain clinics is lowest, poorest. We're now extending our work into post-surgical care. We're looking at whether or not text messages can be used to help people to taper off opioids after surgery more rapidly and without any impact on their pain, so that, you know, not affecting the quality of their pain management, which is very important. And we're, as Amy is going to tell you about now, we're also now extending our work to other medications to understand how we can help people to manage pain with less reliance on medications and more reliance on these sort of psychological and social and behavioural strategies. So now I will pass it on to my colleague Amy McNeilage, who is a Senior Research Officer in the Social Cognition and Pain Lab, and she's been with us for the last 3 years, and we're hoping that with funding from donors, we'll be able to keep her for the next 3 years as a PhD student.
Thanks, Claire, and thanks also to everyone who has joined us tonight. Let me just share my screen. So, as Claire just said, I've been with the Pain Management Research Institute for about 3 years now, and my work has primarily involved patient experiences of using and also tapering off opioid medication. As you've just heard, the opioid crisis is really at its core about a crisis of access, and that's access to good quality evidence-based care. Australian research shows that the majority of people in Australia who are living with chronic pain manage their pain exclusively with medication, and that's usually medication that's prescribed by their GP. Now, until quite recently, that was more often than not opioid medication, various different types of opioids. However, as I'm sure most of you are aware, there has been quite a bit of regulatory pressure on doctors to get patients off opioids. And now, because of this lack of access to other forms of treatment, many of them are being transitioned onto different types of medication. In Australia, the biggest medication that has sort of emerged in this space is a class of drugs called gabapentinoids. So when I say gabapentinoids, I'm really talking about two types of medication. There's gabapentin, which is sold under the brand name Neurontin, and there's pregabalin, which is sold under the brand name Lyrica, which I'm sure many of you have heard of. So both of these medications are currently approved in Australia for the treatment of both epilepsy and neuropathic pain. So neuropathic pain is pain that is associated with damage or disease to the nervous system. It's also called nerve pain or sometimes neuralgia. Now, gabapentin is only publicly subsidized in Australia for the treatment of epilepsy. So when we're talking about people with pain, we're more often than not talking about pregabalin, which is known as Lyrica. Now, you might be wondering how a drug that was initially designed to treat epilepsy has become such a big player in pain management. And it's a story that will be familiar to some of you. The pharmaceutical companies that make these drugs mounted a very aggressive marketing campaign in Australia and many other countries around the world to push Lyrica and gabapentin for pain. And this occurred by no coincidence at the same time that doctors were looking for safer alternatives to opioids. Now, to date, Pfizer, the pharmaceutical company, has paid more than $3 billion in fines and settlements for promoting off-label uses for these drugs. When I say off-label, I mean uses that they're not currently approved for. And when we're talking about pain conditions, this is often conditions where there's really no good evidence to support their use. So pregabalin, again, Lyrica, was first introduced in Australia in 2013. And as you can see from this graph, prescription rates have escalated in the years since then. Over the last couple of years, more than 4 million prescriptions for Lyrica have been dispensed in Australia each year. It recently overtook opioid medications like codeine and oxycodone to be the most common prescription pain medication in Australia. So, as I said, pregabalin is approved in Australia only for treating neuropathic pain, not other forms of pain. So about 20% or 1 in 5 people who live with chronic pain experience neuropathic pain. The other 80% experience other forms of pain that are associated with other forms of tissue like bones, ligaments, things like that, muscles. So despite the fact that pregabalin is only approved for neuropathic pain, there have now been 6 or 7 Australian studies showing that it is widely being prescribed off-label, so for unapproved uses, for forms of non-neuropathic pain where there's really no evidence to support its use. One of these studies found that about half of the people who were prescribed pregabalin in primary care did have a diagnosis of either neuropathic pain or epilepsy in their records. However, the remaining did not have either diagnosis in their records and typically had other chronic pain conditions like low back pain and migraines and other things. So there are several concerns about this recent rise in the prescription of gabapentinoids. The first one is that evidence suggests that the efficacy is very limited. So some people with neuropathic pain do experience benefits from this medication. However, even within neuropathic pain, it's only a minority of patients, and it's generally only a modest effect. However, in other forms of pain, there's really no evidence to support its use. At the same time, these medications are associated with a whole host of unpleasant side effects, and some of which are quite common. They include things like cognitive impairment, weight gain, dizziness, sleepiness, fatigue, and other things. There are also increasing reports of a withdrawal symptom associated specifically with Lyrica. And the symptoms of this withdrawal are quite similar to opioid withdrawal. So it's things like sweating, nausea, vomiting, insomnia, anxiety, and it's also Lyrica is also very risky when it's prescribed with opioids and benzodiazepines. So it increases the risk of central nervous system depression, which in extreme cases can lead to coma and death. And over the last decade, there has been a significant rise in the number of poisoning and deaths that are related to Lyrica. It's important to note that in almost every instance of a Lyrica-related death, there was another sedating drug involved, and it's often opioids or benzodiazepines. This is particularly concerning because we know that in chronic pain patients, the statistics show that in people with chronic pain conditions, Lyrica is often being prescribed with opioids and in some cases also with benzodiazepines. And this is particularly true in disadvantaged communities. On top of all of this, there's now mounting evidence for harms, including misuse and dependence associated with these drugs, again, particularly with Lyrica. We know that they're being used recreationally within the community. The Therapeutic Goods Administration, the TGA, recently added boxed warnings to these medications to highlight these risks. And there's actually an ongoing TGA investigation into misuse and dependence of pregabalin and gabapentin. So the crisis of opioids and this emerging crisis of gabapentinoids, it really reflects the problem of a lack of access to high quality non-pharmacological strategies for managing pain. If we don't address this problem of access, we're really just shifting the problem from one class of drugs to another. The Pain Management Research Institute, where I work, is leading research efforts to increase access to pain self-management strategies using digital technology, which Claire just spoke about, with the support from generous philanthropic donors.
Thanks, Amy. Thanks so much. Thanks, Paul and Claire as well. There's so much to discuss. There's so much to learn. Your work is so valuable. And of course, the Pain Management Research Institute is aiming to become a global leader in providing pain management solutions that will lift that burden of pain off the community. If you'd like to support their work, You can always make a donation at painfoundation.org.au. I know that at the moment they're seeking funding partners to support the research into the gabapentinoids. So there's an email address there as well on that slide. If you have any feedback from tonight's webinar or any questions that you think of later or that we don't get to. But just a reminder, please use your Q&A box or your chat box down at the bottom of your screen. We do have quite a few questions coming through. So we'll try and zip through them. First of all, from Ben, this one is for Claire. Thanks for your question, Ben. Claire, Ben's asking, is the anonymity of SMS preferred over more personal tech, like something like FaceTime? Claire, over to you for that one.
Thank you. So I would say that probably everyone, we should be aware that everyone has different preferences, and that, you know, just because if 80% like the idea of SMS, that doesn't mean, you have to remember there are 20% that prefer apps. So we're certainly not thinking that SMS is a panacea for everyone. What we are doing is trying to develop tools so that for those individuals who find this to be acceptable and feasible and satisfying and useful, that those people get that help. So we're not trying to take over the role of clinicians. We're not trying to compete with any other pain management approaches. This is just another tool in the toolkit that general practitioners and pain medicine physicians and psychologists can offer to patients who are struggling if they find it useful. And so far, we're finding that a lot of people do. That specific question, however, I can answer because researchers have found that actually people prefer not to interact sometimes. And actually one of the social consequences of chronic pain often is a desire to withdraw from others and withdraw from social interaction. And, you know, one of the therapeutic strategies that can be quite effective is to encourage social interaction, but there is a motivation there is a reluctance to do so. And so actually, SMS can be preferred often, particularly by people who are suffering with chronic pain, because there's a desire not to have to talk to anyone. And sometimes just receiving a text message is just all they can manage. And they prefer that actually. So, and by they, I mean particular people. So again, it's not for everyone, but it's for some people.
Thank you, Claire. Okay, here's one directed for Paul. This is from John. Does PMRI and researchers speak with GPs, pharmacists, pain physicians and physios about chronic pain? It's a good one. Over to you, Paul.
Well, yes, I, as well as being a university academic, I also work in the pain clinic at Royal North Shore Hospital, the Pain Management Research Centre. And so, yeah, I work with patients I work in clinic a day a week. I see a lot of patients, and I work in a multidisciplinary team, and we communicate closely with the GP. But, you know, I think the whole thing about opioid tapering has become very controversial, that's for sure. I know that there are a lot of people out there who are taking opioids and find them effective long-term, and they're taking them without any problems. And I want to make it clear, maybe we didn't kind of make this point, but we're not saying that opioids should be banned or that everybody taking opioids needs to come off them. But the reality is a lot of studies have shown that opioids don't work that well for most people who've got chronic pain when they take them for a long time. It maybe even makes it worse. And many people find when they come off them, they feel better and their pain's no worse. It might still be there, but it's no worse, and they realise that the opioids weren't actually doing as much as they thought. But yeah, we're not advocating what's been called forced tapering. And studies from America in particular have shown this can be dangerous, and that it can lead people to get depressed, commit suicide, resort to using heroin. So what we're talking about is a shared decision between doctors and the patient that maybe, you know, there are other things to do than be taking opioids, and that maybe they'll feel better afterwards, and that it's not just taking them off it like quitting smoking. It's actually done by replacing the opioids with other ways of dealing with the pain, like a pain self-management program. And like I showed on that graph that I showed, for 90% of people who choose to do that, it works, and they get off opioids and they stay off them. So I think if a person, if it seems that the patient and the doctor agree that the opioids aren't really helping and a person would like to get off them, that this is possible for people if it's part of a broader program of providing other kinds of pain management and slow, gradual reduction, and not suddenly stopping them, but cutting them down over a long period of time. Right, thanks.
Great, thank you, Paul. Okay, this question's from Louise. This is directed at Amy. Amy, can you define neuropathic pain?
Sure. So neuropathic pain is pain that's associated with damage or disease to the nervous system. Neuropathic pain, there are many different types of neuropathic pain and many different causes of neuropathic pain. It can be from things like different types of viruses and illnesses. It can be a consequence of chemotherapy. It can happen as a result of a trauma or injury. There are lots and lots of reasons that people experience neuropathic pain. The way in which it differs from other pain is there are other forms of pain that are associated with damage to things like bones and muscles and ligaments and tendons. So those sorts of pain wouldn't be neuropathic pain, although it's true that many people will experience neuropathic pain and other forms of non-neuropathic pain at the same time. So they're not mutually exclusive.
Great, thank you, Amy. We're getting quite a few questions coming through. Thank you so much. We'll try and get to as many of them as we can. This one's from Jack. I think for Claire, this one. Why do the Australian studies you mentioned have such small sample sizes when talking about tapering patients who experience no negative effects when tapered?
Well, I only mentioned the studies that we've conducted ourselves, and we've used a qualitative approach, which is not based on a quantity of data, but rather understanding the rich experience of individuals. So it's just a different methodological approach, and it's not more or less valid. When we look at the data in context, we can see that there are a number of people, a large number of people, too many people who are having adverse reactions to tapering. And we recognise that there are serious harms associated with tapering when it's done in a forced manner, when it's done too fast, when it's done without support, when it's done against the will of patients. That is not something that we advocate. That is not something that we support. What we are doing is trying to develop a way of supporting patients who want to taper, who choose to taper, who are not receiving benefit from their medications, who are only experiencing a majority of harms. And that is the population that we are trying to support, those who want to taper, but find they can't because they're not getting enough access to care that supports them to do what they wish to do. So it's very important to be clear that we are not advocating that every patient should be tapered off opioids just because they're on them. What we are trying to do is to support those patients who choose to do so. And yes, you're right, there is very compelling evidence from the United States that when people are tapered off without health systems in place and support in place and social supports in place to help them to do this, and if it's not their choice, then these adverse side effects are more likely.
Thank you, Claire. Okay, this question from Suzanne. Thanks, Suzanne, for sending this one through. When are patients going to stop being blamed for the crisis?
Well, I'm not really sure. I don't believe we said anyway that patients are being blamed for the crisis. I mean, I think what we've been trying to say that this so-called opioid crisis is a manifestation of a much bigger problem of a lack of access to multidisciplinary treatment. The reality is less than say 2% of people with chronic pain go to a pain clinic where they can get the kind of treatment that seems to work best. And that's why we've been exploring delivering it in other ways, such as with text messages. But I think that's the problem, and it's not the fault of patients. I would never say that, just like we're definitely not talking about forcibly taking people off opioids if they're working. But I think a lot of people are interested in a healthy lifestyle and trying to avoid taking medications and other things. And so there are options for them now. I think we're trying to say that they're not stuck on opioids if they don't want to be, rather than everybody who's on them need to be taken off them.
Thanks, Paul. Questions are coming in thick and fast. This one I think is for Amy. This is from Eileen. Thanks so much for sharing this, Eileen. Eileen says, I've suffered from chronic pain since childhood due to a number of medical issues. 20 years ago, I attended a pain management clinic. It changed my life. I stopped taking opioids. However, since that time, I've continually been pressured by clinicians to take opioids to manage my pain. I can't remember the number of times I've been told that I don't have to live with the pain. There is medication. I will not take opioids, and therefore I am seen as not wanting to help myself. How do I manage this and maintain the confidence of my doctor? Good question, Eileen. Thank you.
Yeah, thank you for sharing that. And I'm sorry that has been your experience. I do think that, so as I sort of said in my presentation, more recently I've been working on gabapentinoids, and I've been interviewing many people who have experience with using gabapentinoids, and actually a lot of them have had sort of similar experiences to you, where they've had, to come off it for whatever reason, or they've had really awful experiences on it, and then have found that either the same doctor or other doctors have continually recommended the drug to them over and over again. So I do think that is, I don't think you're alone in that experience. I think that, because a lot of GPs are in a position where they don't have easy access to good alternatives for people. I'm not surprised that there is a tendency to re-recommend opioids. In terms of managing this with your doctor, that's unfortunately not really my area of expertise. But I do think that it is it definitely is an issue.
Thanks, Amy. Okay, a question here for Paul, I think, from Kev. What would the panelists say to someone who is tapered 25% from baseline, precipitating a post-acute withdrawal syndrome for over 2 years? Mm-hmm. Not everyone's given a choice. Surely the protocol should be a 10% protocol. Yeah. Paul, over to you.
I agree with Kev. I think what's called medicine-wise, which is kind of like the TGA's kind of, patient kind of guideline thing now, is saying that it ought to be like 10% a month. And I think I think this kind of thing at 10 or 25% reduction a week was when it first started in 2016 in America, and part of that whole forced tapering thing, and did cause a lot of that kind of problem. That's what we're just saying. I think if you don't do it slowly and carefully, it can cause a lot of enduring problems for people. I think, now we find not only should it be very slow, but people can even need to plateau it for a while if, say they have an operation, or their dose might even need to go back up. But there ought to be some kind of plan to try and get it down. I think I just had one other thing that hasn't really been discussed, is like, why try and reduce the dose? And is it about like a temperance league thing and we want to have everybody completely abstinent, or is it a safety thing? And I think that, the guidelines are that people really shouldn't be taking more than 100 milligrams a day. And that's because of data that the adverse effects of opioids is dose related. So you know, most people come to a pain clinic are on less than 100 anyway. And, you know, so I think it's good to try and get it down. I don't think it necessarily has to go down to 0. I think the lower the better. It just, if people don't want to be on them, less likely to cause side effects like constipation and cloudy thinking, still there if they've got a component of their pain that responds to it. So I think it's about reducing it, but not necessarily, you know, having to stop it. But yeah, a lot of people just don't want to be taking pills anymore, and they want to know how they can get off them. So yeah, it's definitely not, you know, one size fits all, as they say. You know, you cannot just say has to come down by X% every kind of some set unit at time. It has to be much more individualized.
Thanks, Paul. Thanks so much. I think we're going to wrap it up there, but if you would like to submit any more questions, you can email info@painfoundation.org.au and we'll forward them on. And again, the Research Institute is aiming to be a global leader in chronic pain management. They're always looking for support. You can support them by donating at painfoundation.org.au, and as we mentioned earlier, they're seeking funding partners to support the research into gabapentinoids, and that email address there, you can contact them there as well at any time. So thank you so much to our speakers, Paul, Claire and Amy. Thanks to Vocus, who provided the webinar services for us pro bono tonight. Just a reminder that this webinar has been recorded. It will be edited down and it will be available on the Pain Foundation website. And we will be sending the audio link to various media outlets as well. So thank you everyone for joining us. Thanks for your time. And I trust this has been an informative presentation for you all. Thank you. Good night.